everyone. Thank you for joining us today for the pre-application webinar on improving management of symptoms during and following cancer treatment. Before we get started, I'd like to provide a few tips for using WebEx so that you get the most out of today's webinar. All attendees will be in listen mode only. Please feel free to submit your questions throughout the presentation in the Q&A panel and select all panelists from the drop-down. We will ask them on your behalf during the Q&A portion of the webinar. If you need to view live captioning, please refer to the Media Viewer panel. I also wanted to note that today's webinar is being recorded and will be posted online at a later date. We also have a feedback survey. Please take a moment to complete that at the end of today's webinar. And now I'd like to turn it over to Dr. Paula Jacobson, Associate Director of the Healthcare Delivery Research Program, who will introduce our speaker.
Hello, everyone. I'm delighted to welcome you to this webinar focused on the recently issued Moonshot RFA on improving management of symptoms during and following cancer treatment. Today's presentation will be by Dr. Ashley Wilder-Smith, who's the branch chief for the Outcomes Research Branch here in the Healthcare Delivery Research Program.
Terrific. Thank you so much, Paul. What you see in front of you is a roadmap for today where I'll be addressing the science that has given rise to this set of funding announcements. We are going to also be discussing the goals and application requirements, and I will then be addressing common questions that were sent in advance, and to the extent that we have time, additional questions that you all have today, and we'll have information about frequently asked questions at the end. Do please note that questions about specific aims or grant application details will not be addressed today. So I'll first be providing you a brief background on these RFAs. The Beau Biden Cancer Moonshot Initiative was funded as part of the 21st Century Cures Act. The Moonshot was designed to accelerate efforts to prevent, diagnose, and treat cancer and achieve 10 years of progress in 5 years. Pretty bold initiative. The associated Blue Ribbon panel included an implementation science working group, and that group was really charged with identifying opportunities for practice change that could accelerate cancer prevention, detection, and control. That group concluded that given the evidence of harmful effects of poorly controlled cancer symptoms, there's a compelling need to improve symptom care. And to address this issue, they called for a strategic research investment to both identify and test methods for accelerating adoption of integrated systems that both collect patient-reported symptom data and use these data to trigger a clinical response consistent with evidence-based symptom management guidelines. So the RFAs that I'll be discussing and describing today were developed in direct response to their recommendations. Now I'm going to say a little bit more about the scope of the problem. We know from the evidence that across cancer stages and phases of care, 1/3 of patients have 3 or more moderate to severe symptoms, and those symptoms often go untreated or undertreated. There's also evidence that poorly controlled symptoms contribute to non-adherence with prescribed therapies, and this, in turn, decreases treatment effectiveness and increases risk for recurrence and death. Also, evidence exists that poorly controlled symptoms are a frequent cause of ER visits. Many of these lead to hospitalizations, and not surprisingly, they contribute to impairments in physical and social functioning as well as poor quality of life. Among patients who have completed treatment, we have also seen that poorly controlled symptoms, such as pain and fatigue, contribute to lower rates of return to work and an impaired ability to work for those who do return. Consistent with the research literature, the Blue Ribbon Panel Symptom Management Report identified major barriers to effective symptom control. Although clinical trials typically require assessment of symptoms in routine clinical practice, symptoms are frequently not systematically assessed. And despite their availability, patient-reported outcomes, or PROs, have yet to be widely implemented in many practice settings or automatically integrated into the electronic health record. We really identified as part of the report that came from the Blue Ribbon Panel Symptom Management Group that researchers needed to foster widespread adoption of these measures and their use in clinical decision-making in cancer care. Another major barrier is that patient symptoms are often not adequately managed. While evidence-based symptom management guidelines exist, They have not been systematically applied, and many clinicians are unaware of them. And finally, we've seen that clinical trials have shown benefit of integrated symptom assessment and reporting, but we lack that translation into routine clinical practice. And thus, more work is really needed in this sort of phase 3 of the translation continuum that you can see provided at the bottom of this slide. So that's really the evidence base that gave rise to these RFAs, and I'm going to talk a little bit now about the goals that we have for these RFAs. Overall, our desire is to create a research consortium, and that consortium is designed to develop scalable and transferable sustainable symptom management systems in order to address and manage common cancer symptoms. The design is to rigorously examine the impact on symptom control and functioning, as well as on treatment delivery and healthcare utilization, and I'll say a little bit more about that in some later slides. Using consortium-wide data, we are planning to evaluate effects across symptoms chosen, across the cancer care continuum, and specifically among minority and medically underserved populations. And the idea in the end is to produce findings and materials for wider implementation, keeping in mind that the Bo Biden Cancer Moonshot Initiative was really designed to accelerate cancer research. And what we're trying to do here is develop an infrastructure that will allow us to be able to see the impact on a national scale in the long term. Here you see a schematic of the consortium. There will be 2 RFAs that are going to support 4 cooperative agreements that will support 3 research centers and 1 coordinating center. As cooperative agreements, there will be substantial support and involvement from NCI staff. And the coordinating center will also be in charge of managing a steering committee that will include representation from all of the centers and one vote collectively from the NCI. Overall, for the research centers, so these are the ones that have a UM1 mechanism, and you'll see the associated RFA. The overall goal for the research centers is to deploy and evaluate an integrated symptom management system for cancer care. The notion is that we want to be implementing these systems into routine clinical practice, verifying whether the adoption of them can reduce the harmful effects of poorly controlled symptoms, and thus create a foundation for effective and scalable and sustainable symptom management approaches in routine cancer care. I'm going to talk to you a little bit about some of the required components. Relative to study design, the required components include deploying an integrated system in clinical practices, so in a group of clinical practices using implementation science principles. Applicants must propose grants that would use a randomized design to test system impacts on patient outcomes, for example, symptom reports, functional status, as well as cancer treatment delivery, such as adherence to prescribed medications, as well as healthcare utilization, such as emergency room visits. Then they must measure the extent of adoption and contributors to sustained practice change and conduct these in a 5-year project. Relative to the requirements for the integrated symptom monitoring and management system, centers are required to include pain or fatigue, although our preference at the NCI is that they include both pain and fatigue. They must also propose other symptoms that are relevant to the cancer types that are proposed in the application. Applications must suggest studies that provide point-of-care clinical decision support and care coordination based on the presence and severity of symptoms. And please note that management strategies must be based on current clinical guidelines for symptom management. In addition, the applications must look at and account for patient, provider, and practice characteristics regarding proposed changes in clinical practice. Regarding the patient population and healthcare delivery, integrated symptom assessment and management systems must be demonstrated in under-resourced settings and within diverse patient populations. They also must address multiple points, and specifically that means at least 2 points on the cancer care continuum, So that is to include patients who are undergoing treatment with curative intent, patients who are undergoing treatment without curative intent, or patients who are really in the survivorship period, and we're defining that as post-treatment. And then they must measure the extent of adoption and contributors to success. Relative to informatics, requirements include that symptoms must be collected via electronic data capture and integrated within the electronic health record. So one uniform electronic platform must be used for all clinical practices that are incorporated in the research center with a fully operational electronic health record. Options for that include systems that are already embedded within the electronic health record or are able to seamlessly interface with the EHR, such as with online tools, apps, or software with application programming interface capabilities. And data must be collected in formats that allow for sharing across the funded research centers because, as previously described, the research consortium will include pooled analysis across the centers. So I'm going to switch gears for a moment and talk about the coordinating center. And again, the mechanism for that is a U24. The goal overall is to coordinate and support the efforts of the research centers that are funded under the UM1 announcements. And the main responsibilities are listed here: consortium coordination, ensuring standardized, harmonized data collection across research centers, and establishing processes for pooled analyses. Because complex multi-level data will be collected and acted upon from multiple clinical practices for analysis and evaluation, close coordination and efficient lines of communication are needed between the coordinating center and the research centers. So we do recommend strongly that the coordinating center applicants must familiarize themselves with the UM1 funding opportunity announcement as well, and the detailed requirements for the UM1 studies. Additional required components for the coordinating center include providing an overview of the center's roles in the consortium, highlighting unique approaches that show effective and innovative ways to coordinate multi-institutional transdisciplinary research, and describing approaches to that coordination, including oversight of the steering committee and any relevant working groups. I do want to mention that applicants are welcome to apply for either the coordinating center or the research centers, or both, but the same principal investigator cannot be listed for both applications from within one institution. And finally, there's a requirement to comply with resource sharing plan policy that's specified under the 21st Century Cures Act and the Bovine Cancer Moonshot Initiative. And to that end, applicants must describe a process for making resulting publications and, if possible, the underlying primary data immediately and broadly available to the public, or, if applicable, making sure to provide a justification to the MCI if such sharing is not possible. And I did want to note that the MCI will be giving competitive preference and funding priority to applications with a data sharing plan. And this is consistent with all of the funding opportunity announcements that are coming out of the Bovine Cancer Moonshot Initiative. So lastly, I'll just say a couple of words about the grant mechanisms, which I've mentioned already, the U24 and UM1 Cooperative Agreement. So again, as previously mentioned, a cooperative agreement is a grant support mechanism used when there will be substantial federal, scientific, or programmatic involvement. So following the award, NCI staff will assist, guide, coordinate, or participate, and in this situation will be participating in project activities. So you can see on the left side the cooperative agreement components for U24, and there are plans for making one award. The direct costs per year are listed here, and the maximum number of years for funding is 5. And for the UM1 research centers, which is in the right set of the right column, is again, the plans are for 3 awards. The direct costs are listed here per year, and the project period again will be for 5 years. I'm going to say a couple of words and highlight some details of the application requirements. For the UM1 research centers, the research strategy is very detailed, and applications should describe what they are proposing relative to an integrated symptom monitoring and management system, as well as a randomized study to evaluate the integrated system, including recruitment approaches, sample size estimates, power calculations, and activities to manage adoption. For the research centers, the strategy must consist of the subsections that are listed here, A through D, and it corresponds to what's listed in the RFA. And those include overview of the proposed center, the administrative unit, the research design and implementation unit, and data management statistics and informatics unit, and that's how these will be organized. Please note that there are substantial details in the RFA for each of those subsections. For example, relative to the overview of the proposed research center, there are components regarding the overall research direction, leadership structure and key roles, relevant past performance, and a focus on health disparities. And it'll be required to explain how the proposed research center may create the foundation for effective, scalable, and sustainable symptom management approaches in routine cancer care. Now, I'm not going to go into the details of each of the other components. They are long, but please do read them carefully because we provide a lot of examples for strategies to meet the requirements. Regarding the U24 coordinating center, the research strategy must include the coordinating center overview and plans and approaches to basic coordinating center functions. And again, I will not be going through the details regarding these two components, but please read the RFA carefully and think through the pieces that we have already recommended. In terms of the review itself, I would like to remind folks that because this is an RFA and because of the nature of the work, this is a one-time submission. The NCI will not be accepting revisions or revised applications for review. The review panel will be a special emphasis panel that will be designated specifically to review these particular applications, and so will consist of peers in the community who have relevant expertise. And please note and address the special review criteria that are listed in both of the RFAs. So the general review criteria include significance, investigators, innovation, approach, and environment. But for each of those components, we have written additional requirements that are specific to these RFAs. So please note that it is not just generic review criteria. And I also want to highlight that the letter of intent is to be sent to me. My email address is here and will be online and is also listed in the RFA, in both RFAs. So for the research centers, the UM1s, the letter of intent is required. And for the U24 coordinating center, it's recommended. And please note that the letter of intent is due by December 17th. Read the funding opportunity announcements, or RFAs, very carefully, please. I have identified numerous places where there are additional details that you can go through that are for both the research centers and the coordinating center. We have a quick timeline that we are trying to have these both submitted, then reviewed in order that they will be able to be funded by the end of this fiscal year. So the application due date is January 17th, 2018. Please do start the process early regarding your registration in the system for award management, the ERA Commons, and grants.gov. And if you have any issues, we hope you are attending to that in advance so that that doesn't prevent your ability to have your application reviewed. Today's webinar and frequently asked questions are going to be posted on our website. It's listed here. If you don't remember all of that, just make sure to Google healthcaredelivery.cancer.gov, and we will, there will be multiple places where you're able to access that information. Do connect with us early and check the funding opportunity announcements for contact information as needed. So at this point, I'm going to end sort of my formal remarks, and we're going to turn to some questions, and Dr. Sandy Mitchell is fielding those questions that are coming in from you all, and we've collected some that have been submitted in advance.
Great. Well, thank you, Ashley. Just to get us started here, Just wondering, we're getting a question saying, does NCI have any special priority focus by phase in the cancer continuum, such as active treatment, palliative intent, survivorship? Are there any special priorities with respect to cancer type or stage of disease?
Sure, that's a great question. There is no priority focus in terms of clinical populations. Patients that are included in proposed studies can vary by cancer type and may vary by age group. And so we have listed in the RFA that it can include, pediatrics all the way through older adults. Patients who are at least in 2 different places on the cancer care continuum are required. So as I mentioned earlier, that includes individuals who are undergoing treatment for curative intent, treatment with palliative intent, and during cancer survivorship. So at least 2 of those phases is required. And more information about the patient populations and care delivery settings is available in Section 1 of the RFA. Unfortunately, as you print it out, you'll notice that page numbers are not listed at the bottom. So as a result of that, we've sort of identified different places where often when we print it out, that's the page number it happens to be in. For phase of the cancer continuum, it's page 6 as we've printed it.
Great, thank you. Another question coming in, can you explain more about what is meant by integrated cancer symptom monitoring and management systems?
Sure. The integrated system needs to include regular assessment of cancer patient symptoms, so including pain or fatigue, again, preference for pain and fatigue, as well as other symptoms that are relevant for the patient population that's being proposed. So, for example, based on cancer type or stage of disease or treatment modalities. Symptom management strategies should really be based on current clinical guidelines. That's a requirement. And the system also must provide decision support at the point of care. Let's see. And in addition, I guess, to think about the deployment of the practices, they should really be based on implementation science principles. And as you may recall, I was mentioning the Blue Ribbon Panel report, which was coming out of an implementation science group. That's where the symptom management component for the moonshot was really addressed. So those principles should address barriers and facilitators and the ability to enable widespread adoption and sustainability.
Great, thank you. What kinds of technologies are you anticipating will be employed by applicants, for example, tablets, smartphones?
Great question. So we anticipate that applicants are going to use a range of technologies, honestly. I think the plan is for data collection to include electronic data capture that's required using a platform that's either integrated within the EHR or can be a standalone system with interface capabilities within the EHR. But we can imagine, and we know that in the field already, there are multiple sorts of technologies that are being used.
Great. We have another question coming in here. Can you provide more detail about what is meant by addressing health disparities?
Absolutely. A major focus for all of the moonshot activities was health disparities, but for our funding opportunity announcements in particular, we have a focus on addressing both diverse populations, including underserved patients, and each research center needs to address disparities in access to and use of symptom assessment and management. There needs to be a clear focus on inclusion of community-based practices that serve diverse patient populations and have limited on-site professional resources for symptom management. That's a key element to the implementation science component. And clinical practices should include those that provide care to patients who are underserved based on geographic location, race, ethnicity, income, or socioeconomic status, and symptom monitoring and management systems can be tailored for underserved populations. So to that end, low educational attainment, low digital literacy, and non-English speakers are considered within that set of groups. But more information, again, in our RFA for the research centers is found in Section 4, subsection 2, and our printed page 12.
And so just a follow-up question about that, can research centers involve multiple sites?
Research centers can and should involve multiple sites. Right. And in fact, they really need to include multiple sites. This is not something that would be demonstrated in a one-shot, one-center way.
Are sites required to have a shared electronic health record and a portal for electronic CRO data collection?
So again, because the data are going to be pooled across study sites and across them, there should be really one interoperable symptom assessment and management system across the different sites. And that electronic system needs to possess, really functionality for collecting PROs and for providing scored information to clinicians and to the extent necessary back to patients as part of the decision support. So data needs to be collected in formats that allow for data sharing across the research centers, and the electronic platform needs to be either embedded within the EHR or, again, able to interface with the EHR, such as with online tools or apps, software, API, we've talked about earlier, and grant awardees can use the early stages of the project for final refinement of such a platform and refinement of the process of delivering support information to clinicians, as well as any decision support that would be related. And we hope that that part is done very early on and certainly within the first year. And more information about that, actually, can be found on in section 1 and I think on page 7 as you print it.
Question coming in here about sample. Will my application be considered responsive if I have a diverse sample with respect to socioeconomic status, age, and ethnicity, but focus on only one cancer type, such as leukemia or breast cancer?
So patients in the proposed study should vary by cancer type and stage of disease, in addition to being diverse with respect to age, ethnicity, and SES. However, I will say that we are leaving it up to applicants to make some decisions about whether or not there are key questions that would happen within one cancer site, or if you're keeping it constant within a particular stage of disease or whatever. We are trying not to overly prescribe that, but we think that more competitive applications will include variation by cancer type and stage.
While pain and fatigue, you said earlier, are required to be measured, will that be sufficient? Or should I be collecting on other symptoms beyond that? And then a related question, must I use an NIH-sponsored PRO measure such as PROMIS?
Great question. There is no requirement that applications use an NIH-sponsored PRO measure. However, I do want to point you to the common data elements that are listed in the RFA. They're listed in Section 4, subsection 7, and as you printed out, page 16. So those are not required either. We provided those in part for comparability and for folks to have a place to start. But really, symptom domains to be assessed need to reflect the cancer type, stage of disease, and place along the treatment continuum. And so you need to determine both the symptoms that are most relevant in that case, and also the measure selected should have well-demonstrated measurement properties in order to assess whatever you are proposing, and should be feasible for use in a pragmatic trial and easily implemented into clinical workflow, interpretable by clinicians, and really have actionable information to improve symptom management.
Just a related and follow-up question. Would symptoms then, such as psychosocial symptoms, depression, anxiety, emotional distress, also be included?
Those would certainly be included, and absolutely any symptoms that are related to cancer care are fair to propose.
Can the symptom management intervention being proposed address caregivers?
That's an interesting question. The main focus for the application should be on the development of a system for symptom surveillance and guideline concordant symptom management for patients. But as such, you know, the NCI is very supportive of caregiver involvement and integration, and recognizing that they are critical to healthcare delivery and clinical cancer care. So as a result, caregiver participation in symptom management intervention might be one feature of a system for symptom assessment and management, especially for certain populations. And we would imagine, for example, within pediatrics, they would probably be fairly integral. Again, not required, but certainly possible as part of an application and budget allowing, et cetera.
Thank you. We have another question coming in here. What about symptoms for which there are no guidelines?
So that's a great question. There are guidelines, however, really now available for virtually all common cancer symptoms from organizations that include NCCN, Oncology Nursing Society, American Psychosocial Oncology Society, ASCO, and other specialty organizations such as American Urologic Association. So depending on the symptom being, you know, identified and proposed, it would be important to look at the specialty society that would most likely support that for the cancer type that is being proposed in the application. Our focus is on really deploying and sustaining evidence-based symptom management, which is why we are focused on clinical guidelines.
We have another question coming in that says, can we use grant funds to support mid-level providers who manage symptoms?
Oh, yeah, go ahead.
So this is Paul Jacobson. I think I'll handle that one. There's nothing that would prohibit using mid-level providers or funds for that purpose. However, I draw your attention that the goal is to develop transferable, scalable, and sustainable models. And so to the extent that these individuals be supported by grants, that might speak to issues of sustainability.
Thanks, Paul.
Question coming in here, would offering the system for symptom surveillance and management in another language such as Spanish be of value?
Absolutely. So one of the topics that we discussed, or I discussed previously around health disparities and looking at different communities, it would be particularly important to and of value to provide symptom management in Spanish, for example, often because there are barriers and existing limitations in patient-provider communities for predominantly Spanish-speaking communities, and there are many, many Spanish-speaking communities with cancer, so absolutely.
Great. Will you accept international collaborators as subcontractors?
So that's a great question as well, and thank you for asking. If you comb through the RFA, you'll see that non-domestic entities and foreign institutions are not eligible to apply. And non-domestic components of U.S. organizations are not eligible to apply. Foreign components as defined in the NIH grant policy statement are allowed, and you can look at Section 3, subsection 1, on our printed page 9, that gives more information about the international components and the requirements.
Great. Question coming in, will the new NIH clinical trials policies being implemented beginning in 2018 apply to these submissions?
Very important question, and I'm sorry I didn't clarify that previously. As we have gotten an enormous volume of questions about clinical trials changes here at the NIH and specifically at the NCI. And one thing that should make it a little easier for applicants is that the application due date for this particular set of RFAs is before the date for implementation of the new clinical trials policies. So those policies will actually not apply to these submissions. So even though you are submitting, if you're submitting at the end of January to something else, they will apply, but January 18th, they will not.
Can you say anything more about what should be included in the data sharing plan?
So again, the data sharing plan really comes from the Moonshot initiative, and public access and data sharing is required, and specifically to propose processes for making publications and really underlying primary data available as soon as possible, they say immediately, and broadly available to the public. So part of where that was coming from was the importance of making sure that we are collaborating to the extent possible and that data is publicly available. So I know that there's more information, but it's mostly what I've highlighted already. But the full policy is available in the RFA in Section 4, subsection 2A, and I thought that was the printed page 14, sorry. That's why.
That's an interesting question. Can my application include a demonstration of technology to the reviewers?
Oh, wouldn't that be nice? Unfortunately, no, there's really no capacity for inclusion of multimedia materials in an application at this point in time. I mean, I guess just check back with us in a few years and see if that changes, but at this point there's no capacity for such inclusion. If you would like, you could include screenshots if they can be accommodated within the page limits of the application. And the section on preliminary studies can certainly be used to describe technology for symptom evaluation and management that would be employed in the study and provide data from pilot studies, but we don't have the capacity to provide reviewers with actual interactive or any other kind of technology demonstration.
There's a question coming in that says, can you say something about what would be some appropriate study designs, and specifically what would be an appropriate comparison group? Would usual care, for example, be an appropriate comparison group? Kind of a related question is, are step wedge designs acceptable? The RFA mandates an RCT design, which actually is not accurate. But the question says the RFA mandates an RCT design. This might be challenging due to contamination and feasibility. So can you say a little bit about appropriate study design, comparator group, and the use of study designs appropriate for pragmatic trials?
Sure. So we are requiring a randomized design. We anticipate that applicants would use, for example, we actually proposed, we listed as an example in the RFA the employment of a step wedge design or other alternative randomization schemes like cluster randomization that are often employed in pragmatic trials, where the unit of randomization is at the practice level rather than the patient level. Now, that's not a requirement, but we imagine that given that we are having these rolled out among multiple clinical sites and practices within a research center, that the ability to, and again, thinking about the ability to scale up and widespread adoption and sustainability, that the use of such trial designs would be desirable. You can look at Section 4, subsection 2C on our page 13 for information about the randomization.
Another question coming in about design. Is the expectation that outcomes will be actively versus passively collected via the EHR? In other words, is there an expectation that outcomes beyond the symptom management PROs that are integral to the collection will also have to be collected? If so, this will impose a significant expense.
So different proposed designs may require a collection of distinct outcome elements, and some of those may be available in the EHR already, and some may only be available via additional data collection. And there are multiple ways in which, again, people can be organized in terms of their electronic administration So it'll really depend on what you're proposing and what you already have available and the budget constraints based on the system that you're doing it within in your healthcare system.
There's another question coming in. Can grant funds be used to purchase data plans or hardware?
Yes, funds may be used to purchase data plans or hardware. So I'm thinking hardware might be to include things like iPads or other electronic devices or other computer systems if those purchases fit both within the research plan and within the budget that's available. If an applicant proposes to use grant funds to purchase data plans or hardware, the research plan should address considerations of sustainability and scalability once the funding period is over. So again, keeping in mind that if we want these to be able to be sustainable in the long term, we need to make sure that those components are considered.
The comment coming in that the RFA requests and components of it are very broad with multiple levels, yet the budget, $350K, is quite small for these grand aims.
So that's an important clarification. There are two RFAs. One is for the coordinating center, which has a budget of $350,000 in direct costs, and the coordinating center is really not required to do the kind of research and all the sort of broader set of goals related to the integration of the symptom management and or symptom assessment and management system. However, the budget for the UM1 is substantially more at $1.12 million per year, and so that budget should be, fine for the activities that are being requested.
Thank you. The question coming in, do you suggest checking all guideline definitions or using one specific guideline source?
So again, I guess earlier I answered a question about guidelines and that they're really now available for a variety of cancer symptoms. You should really check for the specific set of symptoms that you are proposing to assess and manage what the associated clinical guidelines are and make sure that you are addressing symptoms that have guideline and evidence-based recommendations.
Thank you. I know some people are joining the presentation a little bit late, may have missed part of Dr. Wilder-Smith's presentation. We have a question coming in about whether the institution may apply for the U24 and the UM1 coordinating center.
So yes, and importantly, we wrote these such that any institution may apply to both announcements. One can apply for both. However, please note that each of the applications need to have a different principal investigator for any applications coming from within one institution.
Another question about whether a letter of intent is required and by what deadline.
So the UM1 or research centers has a required letter of intent, and we recommend a letter of intent for the U24. These letters of intent are due 30 days in advance, so it's December 17th. Yes.
Question coming in here asking about whether pilot data is suggested.
Pilot data, it is highly desirable to provide information about prior studies that you've done that demonstrate the ability to do this kind of work. There's nothing specific that says what that has to be, but the section on preliminary studies can be used to describe both technology, and it can be used to describe what's being done in your healthcare system already. It can be used to describe how you've done anything related to decision support or provider communication. Anything related to symptom management in its multiple components are fair to provide.
There's one more question coming in here. Can you please, Dr. Watersmith, tell us what section has the information about the different kinds of study designs that are being solicited?
Yeah, that's on section 4 of the UM1 research centers in subsection 2C, and it's our printed page 13.
Well, I don't think we have any more questions coming in. I'm just looking to see that we got through all of the questions that were posed in the chat, and I think that we have.
Great. So with that, great presentation, and everyone, to our audience, thank you for a lively discussion with all of your questions that came in during the webinar. As I mentioned earlier, the presentation will be posted online within the next few weeks. Please feel free to continue the conversation via email if you have any additional questions that were not answered during today's presentation. Again, there is a feedback survey, and we'd love to hear your feedback on these different webinar series. Thank you again for your participation.